of course, in home health, you have, like you said, marketing is very relationship based, just because, probably because it's an undifferentiated service. You can't really be that different from the next guy since it's so regulated and things like that. What did you find were some of like the top reasons for the drop off or of the referrals, let's say between referral and admission?
Yeah. So there's a couple things. In my system, I kind of stage it out. So a referral moves through more like a traditional sales pipeline, right? You have an opportunity, you've been prospecting, now they're qualified, now you're going to schedule a meeting. So I kind of took that framework and applied that to the referral to admission process, and we came up with stages. So, one of the first stages is just referred. And if you're in a busy territory with a lot of hospitals that are all on CarePort or ADA or any of the referral clearinghouses, that referral volume right there can be really high. In San Francisco, at a top agency that has the relationships, intake people might be processing hundreds of referrals a day.
Wow.
And it doesn't mean that they're going to be placed with them, but they just blast it out and say, hey, who can take this patient? So there's referred. Then there's the referrals that you accept, right? So there's a certain percentage drop off there. We out of territory, out of network with insurance, whatever that might be. So then you accept a certain amount of referrals. Then there's the referrals that are placed with you. So those are three already key metrics and differentiators that I feel are really important to understand what's going on in your on the sales and marketing engine of your business. But the place that really matters is the referrals that are placed with you. So, okay, that to me, the ball's now in our court. The referral's been placed with us. And from there, that's when the stages get really more specific. So two primary areas where referrals drop off. One was so simple, but it was when a referral needed DPCS approval. So the director of nursing or clinical manager, someone needs to review the case and to make sure that we can staff it. If it's a complex wound care, or if it's Foley catheter, maybe we don't have the right nurse right now, but maybe tomorrow. It was those kind of decision points that I found referrals would drop off, because anyone in home health knows the DON is the busiest person in the agency.
Yeah.
At least from my experience, hardest working, busiest people. So that was one area. Another one was the biggest one I found is a referral with incomplete information.
Oh yeah.
Right? So it's missing H&P. It doesn't have a med list. The doctor didn't sign the form. Any of those kind of elements. When a referral comes in incomplete, this was less at the hospital level. Most hospitals send complete referrals in my experience, but when you're looking at the facts from a sniff or, from a doctor's office, and it's just those referrals, what I found is when you needed to follow up to get information, who was doing it, right? So we relied heavily on intake to handle the whole intake process, and they would reach out to the marketer or the community liaison for help when they really needed it. Sometimes that help might be 2 days after we got the referral, because the intake team was so busy, they called, left a voicemail, the doctor's office is busy. So now we're looking at 1 day, 2 days, a patient thinks they're getting home health. We don't have a complete referral. The doctor doesn't know what's happening yet. The marketer's just getting made aware. We're 2 days later, and that's where I found things really started to drop off.